Let me welcome you to Clinical Neuroscience Grand Rounds this morning. Our speaker today is one of our PGY4 neurology residents, chief resident this year, Dr. Phillips. A little bit of a bio on Dr. Phillips is on your handout. He did his he's a local guy, did his medical school training right here, graduated U of L, did his neurology internship in the Department of Internal Medicine here, and then joined the neurology residency program about the same time I joined the faculty here, same year. So we've grown up in U of L neurology at about the same time. He'll graduate in June of this year, and I will spare you the accolades for him. All the warm, fuzzy stuff I'll stay for the residency graduation banquet. I won't talk about it now. I will disclose, though, there's a bit of his bio that's not on your handout. You might notice the title, Consciousness Revisited. Say revisited and consciousness. What a weird topic for Grand Rounds. But not so. Let me disclose to you that Dr. Phillips, before he came to U of L, went to Center College. And as we know, Center College is just a hotbed of free thinkers. Not only was he at a hotbed of free thinkers, he majored in philosophy and psychobiology. Spent half his time there thinking about the consciousness of gorillas, I think he told me. Or at least teaching gorillas how to get food treats from a pan or something like that. And not only you might expect a BA in philosophy, but he got a BS in philosophy. So it's a very scientifically oriented philosophy that basically we're going to hear our philosopher in residence speak today, so pay attention.
Thank you. Good morning. Yeah, I thought a BS in philosophy was very appropriate. And so this was a topic that I spent a lot of time on back in 2002, 2003, and I hadn't had a chance to really focus on it much through my residency, but it's something that's actually pretty relevant to what we do. So in the way of disclosures, I have no financial disclosures, as you might expect, as I'm a resident. But like you said, the most important disclosure was I was a philosophy major, so this may be a frustrating presentation for the scientific types. So the learning objectives basically are to kind of reconsider the meaning behind the term we use commonly clinically of consciousness and kind of what that means to us in clinical neuroscience and how it relates to some philosophical thinking. So the outcomes would be a kind of a new understanding or a reconsideration of the importance of both clinically and philosophically reconsidering the term consciousness. So don't worry, you won't learn anything new today. It's all this kind of repackaging of things we already know, terms we already think we know and that we use very commonly. So I'll start with the meaning of consciousness. Like a lot of things that I'll address today, there's kind of double meanings with everything that I'll talk about. So, the double meanings for this include even the word meaning itself. When I say the meaning of consciousness, what does that mean? So first, I'm going to attempt to define terms. So if we're going to talk about something philosophically or make sure we're all talking about the same thing, we have to define our terms. So I'll try to attempt to define the term consciousness today, to talk about it. But also we'll talk about meaning from a more existential evaluation. So what is the worth or the importance of consciousness? Why do we care about consciousness when we're talking about it clinically? What's the relevance of it? So we'll try to address both of those today. So why does it matter? Why does consciousness matter? Who cares? So this is the second version of our definition of meaning. What is the importance of consciousness clinically and philosophically? And so, philosophically to say something's important doesn't really mean a whole lot because philosophers think anything can be important. Anything esoteric can be important. But hopefully through this talk I can demonstrate that clinically consciousness is very important to lots of things that we do, lots of our approaches in the neurosciences to caring for patients. It's important from diagnosis, treatment, prognosis standpoints, in many of the patients, if not all the patients that we take care of, whether it be PM&R, neurology, neurosurgery. So definition of consciousness. So if you want to define something, you go to the source. So Merriam-Webster, right? Just go to the dictionary. What is consciousness? Okay. So definition, the beginning, the condition of being conscious. You're kidding me, right? That doesn't tell me anything. So then you have to dig further. So we looked and see, what does conscious mean? So conscious, awake and able to understand what is happening around you. Okay? I'll agree that somebody who is awake and able to understand what's happening around them is conscious. Seems sufficient, right? But then the next question is, can we come up with examples where somebody seems to be conscious under our typical understanding, but doesn't fulfill this criteria? So in philosophy, we call this a thought experiment. So thought experiments are great because they don't require IRB approval or funding, right? It's just something you think about. You kind of create scenarios and analyze them and see whether you come to the same conclusions. So this definition of awake and able to understand what's going on around us seems, sufficient, but it's not necessarily a good definition of consciousness. So we'll go back to the source. So some other definitions of conscious. Aware of something, such as a fact or a feeling. Okay, so awareness of something, whether it's, internal or external. Knowing that something exists or is happening. Kind of the same definition as the one before. So now we have something new in there. So we have awareness of something, knowledge of something, and then known or felt by yourself. So this is the first definition that has defined a conscious individual, a self. That seems to be important too. So we seem to be getting warmer on kind of what we mean when we talk about consciousness, particularly from a clinical standpoint. So let's go back to our definition of consciousness from the dictionary. So we had the condition of being conscious. We looked at what conscious was. We thought, okay, that kind of works. There were some additionals. So the condition of being conscious. And so then they go further to expound the normal state of being awake and able to understand what is happening around you. So we would probably agree that somebody in this condition is conscious. But that's not really helpful from a clinical neuroscience standpoint because those patients don't come to our office and we don't see those patients in the hospital. So nobody's questioning those types of conscious patients, consciousness in those patients. These are the philosophical questions, but not clinical questions. This one's interesting. A person's mind or thoughts, and of course, with the philosophy background, this is talking about the mind is what you do in philosophy of the mind. The question of the mind, what it is. So this kind of begs the question a little bit. It just kind of answers our question with different wording of the same question. So consciousness is your mind or thoughts. Well, what is that? Still don't really have a great definition. And then the next one, knowledge that is shared by a group of people. This just gets way off the point of what we're talking about with consciousness. This is a collective consciousness. Well, this is nothing about what we're talking about with consciousness when we're talking clinically. After looking at the dictionary, I found some definitions of consciousness, but nothing that was really satisfactory to represent a definition of terms. If we're going to talk about consciousness in a clinical setting and its meaning, nothing was really convincing. There were some things that were suggestive, but already we've defined a little bit of the problem with the term, with consciousness, why it's difficult. So how about Wikipedia then? So the dictionary, not as helpful. Wikipedia knows everything. So this is the definition of consciousness on Wikipedia. So consciousness is the quality or state of being aware of, so there's that awareness term again, aware of an external object. So this is similar to the definition that we had, to the second definition of Merriam-Webster. An external object or something within oneself. So perception or sentience of something outside of you or awareness of yourself. So as we go through all of these definitions of consciousness that are all varied, the ones that seem most similar to what we're really getting at when we talk about consciousness are some of these words. So how we put them together, I'll make an attempt. But these types of things, these words seem important in an understanding of consciousness. So awareness. And again, we could try to define that and go in further, but I'll spare you that. So awareness, thought, perception, self, knowledge, sentience. All of these types of things give the flavor of what we're talking about when we talk about consciousness. So this goes back to Justice Potter Stewart. So there was in a concurring opinion that he wrote in 64 in a case versus Ohio, talking about pornography. He makes the statement, "It's not the day to attempt further to define the kinds of materials I understand to be embraced within the shorthand description, et cetera, et cetera, et cetera." But ended with, "But I know it when I see it." Again, he was talking about pornography. We're not talking about that today. But consciousness seems to be that type of thing. It's one of those that's so familiar to you until you try to define it. You know what it is, you just can't really define it. So it's one of those, I know it when I see it, you think. And that's kind of how we treat it clinically sometimes, too. We toss the word consciousness around all the time. We ask patients, have you ever been knocked unconscious? If they have a spell, did you lose consciousness? We ask these types of questions expecting an easy yes or no answer. Maybe it's not as simple as we imply. But it seems to, at a base level, it seems to make sense enough that we understand consciousness as something that's just a really day-to-day phenomenon. So we know it when we see it. So if you'll permit me, if you'll grant me, this is going to be my working definition of consciousness in order to talk about it today. Along the way, if this fails or if you have any questions, please stop me, interject. That's how philosophy is supposed to work. So I'm happy to welcome comments. But to proceed, we'll use some of the terms that we had from our list. So consciousness, awareness of one's own, and I'll use one's own, of your own, of yourself, consciousness of a self's thought and or perceptions. So this is kind of a rewording of the same couple ones we had. So the awareness thing is very important. So that there has to be an awareness in there. But I want to put a heavy emphasis on thoughts and not as much on perception. So perception from a clinical standpoint is important, but philosophically, perception can probably be rolled into the term thoughts as well. And so, it's not a good neurology grand rounds without a picture of an old dead guy with funny-looking hair. This guy's not a neurologist, so this is René Descartes. And so, kind of most famously, he's known for the cogito ergo sum, which actually didn't occur until, I think, 1643 in one of the later writings. The same concept occurred earlier in his writings. And so in his discourse on methods, it was written in French, and so it wasn't cogito ergo sum because it wasn't written in Latin. And it was a little bit different of a concept, existentially speaking. I think probably the best and most famous, and he did this one in Latin after reaching a wider audience, was the Meditations of the First Philosophy. This is the one that you read in all of your intro to philosophy books in undergrad. So in this, the Latin actually translates into "I think, I am." So it leaves out the "I think, therefore I am." I think in the 90s Bart Simpson culture, "I think, therefore I am" got kind of watered down into this statement.
He said, "Je pense, donc je suis." I think, therefore I am. I mean, that's really in the French. It's perfectly straightforward translation.
And that, I believe that was in the discourse.
Yeah.
And then later
in the French.
In the French. And then again, cogito ergo sum later. But in the Meditations, in Latin, it was a little different.
Okay.
Whether it matters very much is definitely a good topic of debate. But either way, it's a pretty profound existential statement. And I think it expounds on the importance of thinking in consciousness. And so, what he said was that thinking is enough for existence, is sufficient for existence, that thought itself. And so it's not just that thinking's good, but it's, again, a profound existential statement that thinking in and of itself is enough for existence. We don't need necessarily these perceptions that we're talking about. That just the thoughts is all we know. That all we know is our own thoughts, that our perceptions merely exist as thoughts. So this is similar to kind of a discussion I had with a patient yesterday with kind of a chronic pain syndrome, was that kind of, all pain exists in your head. And so all experiences exist in our mind or in our consciousness. And so that's kind of how the basis, I guess, of these meditations of first philosophy is that the thinking is the only thing that we kind of firsthand know, is the thoughts, the awareness. So even the perceptions can be just thoughts, and hopefully we'll make it to talk about that first. So when we talk of things philosophically and defining these things, something like consciousness, we use necessary and sufficient. So we talked about sufficiency a little bit already. So is this that we use in the definition, is this sufficient to account for consciousness? Then we also have to talk about what's necessary. What is the necessary parts? What is the minimum amount that you have to have consciousness? And so from a clinician standpoint, I think about this kind of like defining MS. So multiple sclerosis, is a clinical diagnosis, and you have to have certain things to, minimum necessary components to meet a criteria of MS. And so there's a minimum amount that's necessary, and then you have to have certain ones to be sufficient to meet the clinical diagnosis. So this is kind of the same thing. We're going to try to determine what the criteria are to be necessary and sufficient to define consciousness. And so, like I said, Descartes' cogito really says that thinking is sufficient for existence. So along similar lines today, we're not going to be talking about existence, but we're talking about consciousness. And so thinking from the same standpoint as our experiences seems to be both necessary and sufficient for consciousness. So when we talk about consciousness, we're talking about thoughts. We're talking about thinking. And I hope to demonstrate some difficulties clinically between what we currently think of when we think of consciousness, which is probably heavily weighted in perception, and what we and probably family members in general think of or mean when we talk about consciousness. And so I won't talk about artificial intelligence today. When we talk about what types of things are necessary, and the necessary and sufficient for thinking. So in the world of philosophy, Alan Turing, John Searle, they've addressed this debate on, can computers think, talking about artificial intelligence, strong and weak AI. I think from our standpoint, for me, it's an interesting philosophical topic, but it's not an interesting clinical topic, really. It's not really something we address clinically. We take care of human patients with human brains, and that's really what our goal is. So rather than getting deeper into the argument, we'll say that from our standpoint, from a clinical standpoint, brains are necessary for consciousness, or brains are necessary for thought. It seems like a reasonable statement to make. That's what we do. If we didn't think they were necessary for thinking, for thought, and for consciousness, it would make everything else we do irrelevant. So that'll be the first kind of bold statement I'll make. Brains are necessary for thought, at least from a neurology standpoint. So back to our thought experiment, let's look at some of the conditions that we see on a regular basis in clinical practice, and kind of decide where, at a basis we say whether these patients are conscious or not conscious, but re-examine based on our definitions and our kind of general thinking. So we'll start with disorders of consciousness. It seems a good place to start. Brain death is complete and irreversible loss of brain function, including involuntary activity necessary to sustain life. So this is actually, legally speaking, one of two ways to determine death, not just brain death, but just death. So if a patient is dead, has brain death, they're dead. They're legally dead. This is from the Uniform Determination of Death Act. And so it seems an easy next step to say, well, these patients do not have consciousness. I don't think anybody would argue with that. So we go to the next step up in disorders of consciousness, into coma. And so coma has been one of those terms. Again, there's lots of different definitions of coma. But it's a state of unconsciousness as part of the definition. Coma is a state of unconsciousness. So in our question of whether they're conscious, it defines that for us in the opening statement. By definition, is a state of unconsciousness in which a person cannot be awakened, fails to respond normally to pain, light, or sound, so to external stimuli. They exhibit no perception. They lack a normal sleep-wake cycle, which we would determine by EEG, and they do not initiate voluntary action. And so it's a little difficult there. Let's go to the next definition. Patient lacks awareness. So back in our definition, the awareness or the unconsciousness, I guess, go hand in hand. No sleep-wake cycles, and displays only reflexive behavior. And so I guess Plum and Posner classically described unarousable unresponsiveness as a kind of quick summation of that. And I think that goes along with our clinical definition of coma. It makes a lot of sense. And so in the definition of this, we say the patient has no consciousness. And it would seem that way. That's the way we would explain it to family members, and that's the way we think about it clinically. But the way we define consciousness, or the way we define coma clinically, again, is a behavioral way, because that's how we examine patients. We lack their ability for subjective experience, so it's just via the behavioral examination of the patient that we determine this.
We need to put reflexes in here somewhere, so they can respond to stimuli.
And so that's in the second definition there. Only displays reflexive behavior, and I put an asterisk next to that. Because reflexes is an interesting thing too. We think about with the spinal type of reflex, the flexion reflex we see, which often can be very confusing to family members. Get a triple flexor responsive, and it seems like purposeful movement. But interestingly, this made me think about things that are other reflexive responses that seem to be more conscious in nature. For instance, pseudobulbar affect, so laughing and crying are reflexes. And we wouldn't expect them to be present in a patient that's in a coma, but technically speaking, that's a reflex, but it seems more related to consciousness than flexion reflex. So that's why I put an asterisk. I still think we would consider that there's probably not consciousness in a coma patient. But if you get asked that question, how do you know? Well, we know because we don't see any evidence that there's consciousness, and that's kind of how we answer the question. So I'll leave that one hanging. We'll move on. Persistent vegetative state. So the patient has sleep-wake cycles, but lacks awareness and only displays reflexive and non-purposeful behavior. So unresponsiveness, wakefulness syndrome is maybe another term. So similar to coma, the only difference seems to be the wakefulness, the sleep-wake cycles. That's the main difference between coma and persistent vegetative state. So some presence of eye opening, either spontaneous or induced, that's never observed in coma. So that is kind of the definition of not being in coma anymore. You have some arousal, some awakeness, whether it's sleep-wake cycles or opening of the eyes. Otherwise, the definition remains the same. And I think, and again, remains the same behavioral aspects that we talk about, whether there's any purposeful movement. So it's only still reflexes. And so even in this scenario, we say there's no awareness. This is presumed from a behavioral standpoint. And so then we move on to a minimally conscious state. Well, just in the term itself, it implies that there is some consciousness. They're minimally conscious, but they're conscious. So severe altered consciousness in which minimal but definite behavioral evidence of self and environment awareness is demonstrated. So what counts as awareness, we've kind of questioned coming into this. We've said before, well, there's no awareness. In these patients, we're demonstrating we think they have some awareness because occasionally they have what appears to be purposeful behavior. They may not always have it, so they may not always be conscious. But from a sufficiency standpoint, they've met that by demonstrating to us behaviorally that they have behaviors that are evident of awareness. So from the previous three definitions, we thought, well, they probably weren't conscious by the definition. But it was really just absence of evidence of it. So again, absence of evidence is not evidence of absence, which is why people still look for Sasquatch and Loch Ness Monster, because they haven't found it yet, but that doesn't prove it's not there. They just haven't found it. So this is a similar problem in patients. And we get these questions from family members all the time too. Well, how do you know? How can you prove it?
Justin, just before we move on, so I want to make sure I understand your thoughts or where the cutoff is. As far as vegetative state, by the definitions that you were using or what you've said, is the thinking that vegetative state is a level of consciousness or a level of unconsciousness? Or has that been defined yet?
So based on the definition, it says they lack awareness. So for me, from our working definition of consciousness, this would say they are unconscious, that they're not conscious.
Well, and so we can talk about this at the end of your discussion, but the fact, there's lots of other reasons to argue against that. The fact that their eyes are open, the fact that they have a sleep-wake cycle, one in which is a higher level of consciousness than the other, and the fact that many of these people actually have physiologic responses to pain with changes in heart rate and things of that nature would suggest an internal level of awareness that we can't measure because our level of measurement is not sufficient. So.
And that's kind of what I'm driving at with the whole thing is that kind of from the definition we mentioned no awareness, but then again, what do we use as our definition of awareness? Even if it's a lower level, we would call it lower level consciousness. Is that still consciousness? What's adequate? What's sufficient for consciousness? And so hopefully we won't get answers today, just more questions. So what is necessary? The brain. I think the brain is necessary. So in our profession, the brain's necessary. So what about, is the brain in and of itself sufficient for defining consciousness? Well, I think we would say, yeah, a normal brain attached to a normal person in good working condition is sufficient to say that they have consciousness. They can demonstrate, we see it behaviorally, we'll just make that presumption. It seems to be. But then the question is, well, how much of this working brain or combinations of this working brain is sufficient to still have consciousness? Because we see patients with damage to the brain. And the question is, what's the cutoff? Where's the line? Where do you draw the line in the sand? In philosophy, we talk about the paradox of the heap. So 1 grain of sand is not a heap of sand. It's 2 grains of sand, a heap of sand. There's 3. At what point does it change from 2 or 3 grains of sand to a heap? At what point did it have just enough brain to be considered conscious? So this is the philosophical part of the question. So how much? The cortex seems to be important for us to talk about consciousness, but how much of the cortex? The thalami, do you need both? And how much of the thalamus? The ascending reticular activating system, and then connections between these two. How much is necessary and sufficient? Here's a nice picture from Blumenfeld with the different shading of areas. So the one that's shaded dark at the top, again, is the one that nobody really questions. That's supposed to be brain dead. There's nothing. The brain's not working. But all these others, you can see there's different levels of shading of different parts of the brain. None of our patients ever look like this. They're never this clear. Oh, this much of the brain is affected. The dark blue is severely, and then the light blue is variably. Well, we don't get this nice. This is an overall gestalt of how this should be, but we don't get this in our patients. We have to try to infer this clinically in patients that are otherwise sick and on many medications, and so this is not nearly as clear as it would be in this picture. And so I also want to talk, and I think Dr. Kalin alluded to this when we talk about disorders of consciousness. There's also this kind of classic levels of consciousness that we talk about. And I think within the neurosciences, we probably have gotten away from this, and it's probably a good thing. We don't do this as much anymore, but we still see a lot of these words tossed around. And I think the most common ones that you may remember from Plum and Posner's diagnosis of coma and stupor will be coma, stupor, obtundation, and confusion, and then consciousness. Some of these others we'll see as well, somnolent and delirious. And I want to talk about those a little bit as well. So coma we already talked about. Unarousable unresponsiveness. We'll say, for the sake of argument, those patients are not conscious. So what about stuporous patients? So the definition, sleep-like state, not unconscious. So in the definition, again, they say these are not unconscious. They have little or no spontaneous activity, but they're in a sleep-like state. And so these are people with an even lower level of consciousness with stupor. They only respond by grimacing or drawing away painful stimuli. So they're pretty similar clinically to what we talked about with persistent vegetative state. Because if we're on a continuum and they're not in a coma, and we said this is not coma, From a level of consciousness standpoint, we're left with stupor next. That's the next lowest level. From a disorders of consciousness standpoint, we're left with persistent vegetative state. The implication in persistent vegetative state is they're not aware, whereas this one would say, well, they're not unconscious, which would imply that they're aware. So already I'm finding some difficulties with our clinical determinations of consciousness. And so, I don't know, our people in persistent vegetative state, we would still call them stupors. Maybe it's just not a good term. And so often that's why you'll see we'll say, just describe what the patient can and cannot do. So obtunded is another one of those words. Decreased alertness, slowed psychomotor responses. So in obtundation, a person has decreased interest in their surroundings, slow responses, and sleepiness, implying problems with their consciousness. But we see things all the time, patients we think are perfectly conscious and maybe have a normal level of consciousness that fit this definition. Parkinson's disease, these patients, they may or may not have decreased interest in their surroundings, and they may appear to. They're severely akinetic. They're going to be slow to respond. They're going to look uninterested in their, and so behaviorally speaking, they're going to look like the obtunded patient. The same thing for severe depression, abulia. Often you'll see abulia come up in these descriptions too, because these things kind of go hand in hand and they muddy the waters a little bit. Somnolence doesn't make it in the classic Plum and Posner, but in some of the other literature I reviewed, you see somnolence. This one just really doesn't seem to make sense from a level of consciousness because it's just sleepiness. A somnolent person shows excessive drowsiness in response to stimuli only with incoherent mumbles or disorganized movements. So it seems to be there's an implication of this of some other level of consciousness problem, but really they're just describing sleepiness too. And so sleepiness in us, if you're listening to a guy talk about philosophy now, it should hopefully be a transient phenomenon. But it's similar. So how is it, it's only defined in its ability to wake up from it. So if somebody's asleep, we define the difference in sleep and these other levels of consciousness by the ability to wake the patient up. So the definition is not in the instant, but in the after. So it's only defined by what comes after it. So what about, why isn't this just sleepiness? Well, we only know from the behavioral. And then what about sleep itself? I think that's too deep of a topic to address further today, but we would say somebody is unconscious when they're asleep, but it's a different kind of unconsciousness than we talk about pathologically because they can be aroused from it. And then another very interesting topic would be dreams. And so I'll talk about that later when I talk about apparent consciousness. So in patients that we think are unconscious, there may be some other apparent consciousness. And then, of course, delirious. Neuroscience-wise, neurology-wise, when we talk about delirious, we typically talk about hyperactive delirium. We're talking about the type of patient that looks like DT. Disoriented, restless, agitated, hallucinating, delusional. They look psychotic. And they have altered levels of consciousness. So that's kind of the classic definition, and that's the way a lot of neurologists talk about it. But the things we call encephalopathy, often by other subspecialties now, are addressed as hypoactive delirium. And it's mainly a matter of attention. So the ability of a patient to maintain attention. So geriatrics, psychiatry, palliative medicine, hospice, when they talk about delirium, they include all the patients that we talk about when we just say encephalopathic patients. And so attention seems to be the key there. But again, there's some kind of alteration in consciousness at some point. But how it falls into that spectrum, again, remains difficult. And it remains difficult to then separate it out from this one, confused. This is the kind of bane of the existence of the neurologist when you get a call from the ER. Oh, Miss Jones is confused. Well, that could mean any number of things for us. Or is she just aphasic? What's her level of consciousness? We're talking about that. Using confusion as a level of consciousness is confusing to the examiner because confusion, from the definition, disoriented, impaired thinking and responses. That doesn't require in the definition alteration in level of consciousness. So this includes all of our demented patients too. So just because someone's disoriented and doesn't know what day of the week it is, doesn't imply they have any alterations in level of consciousness. So I would argue again, this doesn't necessarily belong in the spectrum of altered level of consciousness. So again, if we push towards an altered level of attention, then that would put us in a different category of delirium. So I'm not really sure where confusion falls in altered level of consciousness if we have delirium included in there, because anytime someone has altered ability to maintain attention, then that would meet the criteria for delirium. So far our disorders of consciousness are a little muddy. Our levels of consciousness seem very muddy. But we use these types of things all the time to kind of help evaluate patients. And, you know, philosophically, I don't know that it gets at the true question of consciousness and what it is and what it means. But we'll go to conscious. So we'll go back to the original definition, the normal state of being awake and able to understand what is happening around you. Okay, well, occasionally we get patients like this, and we still see them, and the consciousness is still important. And so now we kind of get into that realm of behavioral neurology or psychiatry. And so in addition to these level of consciousness, even a person at the highest level of consciousness, conscious, there's still an attempt to assess the content of consciousness in these patients. So we want to know not just are they conscious, but let's know about their consciousness, aboutness. And so we use the mental status exam for this. And there's kind of varied forms and things that are included in the mental status exam and different interpretation of that. I'm not going to go into depth with it. It's not necessarily widely used now, but I like the idea of the psychoanalytical approach just to demonstrate problems with our concepts of consciousness within a conscious person, just because a lot of these same concepts still hold true in other forms of psychological approaches to patients. So when we talk about the id, the ego, and the superego, most of us remember from undergrad from psychology types of classes. So the argument for this, for the id by Freud, was that this aspect of the personality is entirely unconscious. So in the definition, this is in a conscious person. We're saying this part of their personality is completely unconscious. And that seemed to be acceptable to say that in a conscious person, there's this unconsciousness. This is kind of instinctual things and primitive behavior. So maybe some of these are these reflexes that we talked about before. But he says this is the source of all psychic energy, making it the primary component of personality. But it's unconscious by definition. So it seems a little strange on the surface, yet it's something that maintained in our kind of thinking. So it's driven by pleasure, strives for immediate gratification, desires, wants, and needs. So those things, desires, wants, and needs to me implies some kind of awareness. Yet this is supposedly completely unconscious. Then we talk about the ego. So this is the component that's responsible for dealing with reality. So this is that next connection to the id. And so according to Freud, this develops from the id and ensures that these impulses are expressed in an acceptable way. The most interesting part of this phenomenon for me is he says, the ego functions in the conscious, the pre-conscious, and the unconscious mind. I don't really know what those mean at this point after our discussion of consciousness. What does it mean to have both a conscious, pre-conscious, and unconscious mind? So the same thing kind of holds true for the superego. So this is kind of our higher moral center, for society, etc. But he makes the same statement. It is present in the conscious, the pre-conscious, and the unconscious as well. So, yeah, this is psychoanalytical, Freudian stuff. Nobody really necessarily uses this anymore. But it kind of poses this question. Can thinking, so when we talked about our definition of consciousness, we basically said consciousness requires thinking. It seemed that thinking was necessary and sufficient for consciousness. But then when we talk about kind of mental status exam in patients and some of the diagnoses we make, even without using the Freudian psychoanalytical concept, we still use this kind of strange Cartesian dualism in medicine. That's why we have psychiatry and why they're not here today for our neuroscience grand rounds. Because there's some kind of false dichotomy made between the realm of psychiatry and the realm of neurology. There's the mind and there's the brain. But then we've already spent the first part of this talk talking about how consciousness is in the brain or is of the brain. But yet clinically we still hold on to these kind of dualistic backgrounds. And so can thinking be unconscious? And unconscious, that seems kind of like an absurd statement. But it does still exist in our practice. So we think about unconscious thinking. It seems to be an oxymoron. It seems to be counterintuitive. But what about conversion disorder and dissociative disorder? How many people in this room have diagnosed conversion disorder? And by doing that, we say, well, they don't think they're faking it. They're not aware of it, but they're doing this. They're exhibiting this behavior. So we're talking about an unconscious thinking when we do that. So by our clinical behavior, our diagnoses, we think, yeah, unconscious thinking is possible. So can you have multiple consciousness then? So if you have a patient who's aware of some of their thoughts and not aware of other thoughts, is there another entity other than the patient you're seeing who is experiencing these unconscious thoughts? Because it seems to have a thought, you have to have an experiencer. So what is this other thing? Is there a separate consciousness that experiences these unconscious thoughts? Is that the same person? Which one do I treat and which one do I bill for when I take care of these patients? Which conscious being? So, you think about some of these patients. Some of the patients we see, from some of the pediatric folks are here. You have kids with Rasmussen's. They get hemispherectomies, and they presumptively had normal consciousness after that. Can develop fairly normally. Or we see pretty devastating strokes and taking out an entire hemisphere. Now, those patients are very debilitated, but we don't typically presume that they have any loss of consciousness with them, preserved consciousness. So we're saying, well, you can get rid of like half the brain, and somebody could still be conscious. But now it's getting deep. So what if everybody has two consciousness? One in the left and one in the right hemisphere. One's able to express itself because there's language associated with that side of the brain. The other one, the consciousness on the right hemisphere, is kind of docile, doesn't really do anything. So it's there, but it's a different experience. And so we're not even. So in a normal patient, so what about me? How do I know I have consciousness? How do you know that I only have one? So in a normal patient or in us, we have the corpus callosum. It communicates. And so for us, we'll presume that if we had two separate consciousnesses that are unified by this band of what used to be thought to be supportive structural material, and that communicates and that kind of unifies our consciousness. There are patients that are either born without this or have had this severed and still function, still walk around. So this used to be a treatment for epilepsy. So you basically do a corpus callosotomy. So commissurotomy. These patients, after severing of the corpus callosum, were reportedly pretty normal from a day-to-day life, behavioral life. They functioned pretty normal. And so it wasn't until some experiments by Dr. Sperry back in the 50s and 60s, they kind of demonstrated using this fancy tachistoscope method that there was ability to kind of separate spheres of consciousness in these patients, at least in the clinical setting. And this was the most fascinating thing to me from a philosophical standpoint, the question that it posed. And again, we don't have time to address it all the way today. This little diagram here gives kind of an idea of what they would show. They would flash very quickly. The patient would look into this tachistoscope, and they would flash this picture or amalgam of pictures up in a way that the patient couldn't move their eyes or orient something to where it got to both sides of the brain by crossing the chiasm, etc. So it would only be present to the visual field. And so the presumption is that only one side of the brain would see the I picture, the other side of the brain would see the B picture. The language part of the brain would then say, oh yeah, I saw the B. But then if you allowed the left hand to draw, they could, or to pick the picture out, they would pick the one corresponding to the I, even though the patient linguistically would have no recollection of the I. So the implication philosophically was, well, there's two consciousness. There's two spheres of consciousness. There's the one that saw the one side and the one that saw the other. So then why stop there? So, we talked about hemispheres, and we said, well, maybe everybody has two consciousness, but why does there have to be one per hemisphere? What's the limiting factors? And we talked about the sufficiency. How much needs to be had? So again, we know that patients may have damage to different parts of different sides of the brain. So how much is necessary to have what we call consciousness? And so it becomes kind of a slippery slope, and still kind of begs that initial question of how much and what parts of the brain are necessary and sufficient for consciousness. So there are kind of multiple clinical scenarios where when we think about it at this level, we're left with some more questions. So in Blumenfeld's Clinical Neuroanatomy, where I stole some of these nice pictures, they also have another definition of consciousness, which I think is interesting clinically. So conscious awareness is the ability to combine various forms of sensory, motor, emotional, and mnemonic information into an efficient summary of mental activity that can potentially be remembered at a later time. So I didn't include this one in my definition earlier, but can be potentially remembered at a later time. Because it seems that some kind of continuity of experience is necessary for consciousness as well, at least from a subjective standpoint. So I think that's this potential to be remembered at a later time. And so this, when added to the scenario, this is another concept that makes it difficult to define consciousness and what kinds of states, whether the patients that we're taking care of are conscious. So other clinical scenarios that seem to be confounding are those with apparent consciousness. And so complex partial seizures, we have patients that may have bizarre behavior, and then we find out, well, they're having abnormal brain activity, they're having seizures in part of the brain. So are these patients conscious? When we use the fuzzy terminology of altered consciousness to discern from simple and complex partial. And nobody can ever really say exactly what counts as altered consciousness. And are these patients conscious? No, we typically think if somebody has a generalized seizure, they're not conscious. But if they have alterations of parts of the brain, are they still conscious? Which parts of the brain are allowed to be altered and the patient's still conscious? And then what about things like TGA, or the probably more common, although we don't clinically see it, just alcoholic blackouts, the kids in college that drink too much. They do a lot of things that are behaviorally very much of a conscious person, but they have no recollection of it afterwards. Were they still conscious during this? We would say yeah, but it would seem to them subjectively they're not, because it doesn't fit. It falls out of that continuity of mental activity. And so it seems strange from a consciousness standpoint. It doesn't fit nicely with that very sufficient definition we had at the beginning that was the normal state of being awake and aware and able to remember, etc. Then there's false consciousness. So this goes back to the idea of dreams. So for the experiencer, for the asleep person who would be easily argued, this person's not conscious, you can have dreams that are very vivid and for all intents and purposes are equivalent to your conscious experiences. That's why you wake up afraid from nightmares. So for the experiencer, this is the equivalent of consciousness. But we would probably say, well, no, this is not conscious. But why not? What's the difference? Same thing for false memories, hallucinations, these sorts of things. They occur during waking, so often a patient's conscious, but is the hallucination part of their consciousness? Because it's not caused by the perception. And other cortical disconnection syndromes seem interesting too. So things like blind sight, right? So it appears behaviorally the patient functions as if they could see when they perform the activity, but clearly they don't have the conscious awareness, at least from what we would talk about, this theater of the mind. They don't have that conscious awareness of the activity, or the alien limb phenomena that we see in CBD. All of these things, there seems to be another breakdown in our understanding of consciousness because of the lack of awareness subjectively by the patient, but behaviorally they look like it. So we have contradictions on either side. The other agnosias, etc., can also demonstrate these complications. So I'll leave it at that. I'll leave it open-ended. I welcome questions and discussions. We have a few minutes left. My goal today was to demonstrate that we use consciousness pretty freely in all of these scenarios, but what we're talking about may differ from time to time, and that it's important to evaluate the meaning of that when we talk about consciousness. As Dr. Kaler mentioned earlier, when we talk about patients with a disorder of consciousness, and we're talking about prognosis to the family, we have to make sure that we at least understand the difficulties of consciousness for us clinically and philosophically when making kind of bold statements to families about how loved ones are going to do, or to the patient themselves in some of these other scenarios of altered consciousness.
Listen, what impresses me about the notion of consciousness is that it is on the sensory side of the brain. In other words, Descartes said, "I think, therefore I am." He didn't say, "I do, therefore I am." And so the problem is that if you have a deficit of motoric output, you may not appreciate what the sensory part of the brain is doing. We have a patient on the ward now who had an extensive frontal lobe arteriovenous fistula malformation, and with treatment and progression of her problem, she basically lost both frontal lobes to a remarkable degree where there's very little motor output now, but the parietal occipital areas are not so bad. And so, she's an example of a person where you really wonder. I guess Stephen Hawking's is not so much at the brain level of output, but the neuromuscular side, and with tiny little things he can communicate, and you realize that, if anyone's conscious, I guess Stephen Hawking is. And then there are people where the linkage is the issue, and the people with basal ganglia disorders that lead to, the akinesia of Parkinson's, for example. I think it was appreciated relatively early that these people were conscious, even though they didn't do much. So when you get into these coma states and whatever, they're a hodgepodge of motor criteria.
Right.
And I think if you're really focusing on consciousness, you have to figure out how to isolate the sensory part of it.
Well, I think it's a good point. There's a couple things I think could be highlighted. Number one, if you're looking at this purely from a clinical standpoint, that's hard to do, the sensory awareness side of things. I was part of the American Congress of Rehab Medicine's Disorders of Consciousness Task Force, and we published a paper in the Archives of Physical Medicine Rehab in 2010 looking at all the ways of measuring, all the assessment tools for disorders of consciousness. And the Coma Recovery Scale Revised is currently the most highly recommended in the United States. That was created by Joe Giacino, who you referenced in your bibliography. And so our program here at the University of Louisville, Fraser Rehab, uses that, and so do most of the top programs that deal with patients in that low-level coma, vegetative, minimally responsive state. But it does measures a responsiveness. It measures functional object use and functional communication, which, as you say, are do things, not understand things. On the receptive side, you have to really go to more radiographic types of or functional measures. You're talking about functional MRI, where you show somebody a picture and there's some level of activity change that would suggest a level of awareness that might be created there. So I think those are the types of things that you probably have to be looking at as physiologic responses to stimuli that would suggest a level of awareness, which is different than the ability to respond to your environment.
I think the ability to measure some of these sensory phenomena, I thinking they're going to pose the question how much sensory evidence that you need to then be equivalent to consciousness. So you said you can have heart rate changes from painful stimuli, but whether that's a higher cognitive function or whether that's a more, a lower level of function that, the family's going to consider consciousness, that's, again, those kind of deeper questions that we'll have to address probably later on once we get better technology to measure, functional MRI or that sort of thing, then, how much is enough for families. And I think sometimes our approach to families is to say conscious or not conscious, but the answer they really want, is Grandpa going to be able to go fishing with me again?
Right,
and we have to be sure we
prognosis is the other thing, and so Again, I would just recommend that everybody be very cautious about using these all or none terms that we like to, sometimes we say we avoid, but we like to often throw out there, which is, oh, grandpa's never going to do blank again, or grandma will definitely be able to do something again, because the truth usually lies somewhere in the middle. And for traumatic causes of encephalopathy or disorders of consciousness, there's actually a relatively good outcome of regaining a level of consciousness and some level of participation, less likely so with the non-traumatic forms of encephalopathy, anoxia, metabolic encephalopathies, and so forth. But again, good data out there to talk about those things. And so early on after the development of the disorders of consciousness, I think you have to be realistic but relatively optimistic about an improvement of some level. To what level, hard to say. And then you have to start talking about something that we haven't discussed here, which is quality of life. When does a quality of life start to come in? Is it when you perceive things? Is it when you can interact? Is it when you can control your environment? You know, do you have a better quality of life if you can laugh at a joke or tell somebody to change the TV station, but yet you're still completely dependent? And so that's when people start making decisions, having shared decision making with your patient and their family, and in this case, the family or the care provider, early on in an acute hospitalization about what's the likelihood that grandpa's ever going to go fishing with me again. Or the better question would be, what's the likelihood that grandpa could sit in the living room with me and watch a TV show and laugh at a joke? That's probably a more realistic conversation to have at the early stages.
Hi, I really enjoy your talk. I'm Hao Jianhu. I'm from psychiatry. So I think when you mentioned psychiatrist doesn't come to this kind of thing.
We're happy you're here.
But I think you're talking about sort of there's this dichotomy between mind and brain, and then actually sort of brain produce mind, but mind comes back also affect brain, change brain too, and then sort of it's hard to just separate them altogether. And then also you're talking about sort of how do you make a judgment about another person's behavior or thinking. It takes a second person to make that kind of judgment. So the rest of society making that kind of judgment, saying this patient is sick, this patient is psychotic, that kind of. So all this kind of stuff, it's kind of tangled together, and then it's hard to, because it comes down to about insight and judgment. Sort of how can somebody say I'm psychotic, I need help, that kind of thing.
Yeah, so I guess there's a couple of issues there. One that I mentioned is kind of the dualism. We talk about the mind, which is not a material thing, and the brain, and they interact with one another. And again, philosophically, it's kind of like talking about an immaterial soul and how that can exist and trying to define that. So how is a mind, if it's not a physical object, then able to exert any input, any influence on something physical like the brain? It's a much deeper philosophical question than we can talk about in a few minutes. But it does seem to be a problem because we assume that happens. And, from a psychiatry and a neurology standpoint, that's why we still do psychotherapy, because the thought is, well, we can influence by addressing the mind, we can influence the brain, and we see behaviorally that happens. But scientifically and conceptually, there's really no way to conceptualize that this mind, this immaterial thing that we speak about, that's plus the brain plus something else, has any influence on the physical brain. Yeah.
So in your reading on this topic, have you ever found someone saying that consciousness is a function of the heart, which exerts its effect on the brain, which causes you to think and be aware?
No.
Valentine's Day.
You're in the wrong building.
That building's next door.
Hallmark says yes.
I think the heart is necessary but not sufficient for consciousness.
No, I think the confusion about the heart comes that, when you're excited, you're aware of your heart, and so people talk about, in your heart, but it's metaphoric now. I mean, I don't think anybody, since we discovered that the brain controls the heart.
And we do heart transplants all the time, and worry about somebody having a new consciousness. Certainly, if we're ever able to do brain transplants, there's going to be a lot more moral and philosophical questions that come about when we start brain transplants. So I think that there was probably more ancient texts addressing that, but I hadn't stumbled on it.
Very, very good. I think we should mention somewhere that wakefulness is linked to attention, and attention and wakefulness are in part the function of the reticular activating system, the basal forebrain cholinergic projection system, and the locus coeruleus. All three of these that project diffusely to the cortex and the thalamus also, but help to provide the function of attention, and that actually it's possible for the mind, so to speak, to influence the brain, because through meditation it's possible to focus your attention and practice focusing your attention, and thereby enhancing your capacity to pay attention. So it's a magnificent kind of exercise that is mindful and enhances attention, and must be working through the enhancement of these three projection systems.
Thank you.